Welcome to Delaware Health Care Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board-certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Health Care Reality.
Hi, this is Dr. Nick Biasotto, the host of the Medical Society of Delaware's podcast, Delaware Health Care Reality. Today we have a special guest in cardiology who I've known for over 50 years. We were in the same college together. He was a couple years behind me, but we did have some good times in that college. It was wonderful 4 years of our lives. Well, this is Dr. Ronald Lewis. Dr. Ronald Lewis is a practicing cardiovascular medicine physician, and he's been practicing for nearly 40 years and has been a member of the ChristianaCare team since 2011. As a board-certified cardiologist, Dr. Lewis provides compassionate, experienced care to his patients, and from my understanding, they all love him. Dr. Lewis received his BS degree from the same college that I did, Allentown College of St. Francis de Sales, and now called de Sales University. Dr. Lewis received his doctoral degree in osteopathic medicine from the Philadelphia College of Osteopathic Medicine in Philly. He completed an internal medicine internship at Springfield Hospital in Springfield, PA, and a residency in internal medicine at the Metropolitan Hospital Springfield Division, where he also served as a chief resident. Dr. Lewis next completed his fellowship in cardiology at the Robert Wood Johnson Medical School in New Brunswick, New Jersey. His long career in cardiology includes positions in private practice and with ChristianaCare cardiology consultants in Newark, Delaware, as well as serving as active and consulting staff for numerous hospital systems in the greater Philadelphia area. He's from Pennsylvania now. He's a fellow in the American College of Cardiology and the American College of Osteopathic Internists, and is a member of numerous professional organizations, including the American Heart Association, American Hospital Association, American Osteopathic Association, and many others. I welcome Dr. Ronald Lewis. Hi, Ron.
It's great to be here, man.
Hey, long time no see. Well, not really. We see each other in meetings and things like that. But wasn't that great college times, huh?
It was the best.
The best, I'm telling you.
You were my frat hazing director.
I was?
Yeah.
I forget.
Yeah, you were.
Well, today we're going to talk about POTS syndrome. That's P-O-T syndrome, standing for Postural Orthostatic Tachycardia syndrome. And for the lay people out there that are not involved in medicals, this has nothing to do with marijuana. So the subject here, I'm going to let Dr. Lewis give us a definition of what POTS syndrome means and what it's about.
Yeah, thanks, Nick. First off, I'm going to tell you that as a cardiologist, we as a professional subspecialty do not take ownership of this diagnosis. By the time we get to see many of these patients, they've already seen several physicians because of the symptom complexes they have, and that would include neurologists, allergists, GI people. They would see sometimes rehabilitation people, psychiatrists, a whole slew of different doctors before they finally make it to a cardiologist. So that the thing that gets their attention, and it gets lots of other physician-referring doctors' attention, is the term tachycardia. Mm-hmm. And that refers obviously to a fast heart rate. However, there is a specific definition for this that you'll see in literature, but I got to tell you, the more I read and the more I deal with patients, not everything is black and white. As you know, it's gray. Mm-hmm. But generally, the classically described definition is a person's heart rate will go up by at least 30 beats. I'm talking about an adult, someone who's past adolescence, by at least 30 beats within the first minute or two after standing. Oftentimes, it's very precipitous. And it will stay up for at least 10, 15 minutes over typically a heart rate of 120 beats per minute. Interestingly, and this is helpful in terms of identifying this as compared to orthostatic hypotension, which is sometimes confusing because the word orthostatic appears both in terms of blood pressure being low and in this entity, the pressure in these folks typically doesn't tank. It doesn't go down, at least not immediately. And therefore, what you have is some form of autonomic deregulation or dysfunction.
Okay. Now, autonomic is part of our nervous system.
Yeah.
And I like to liken it to an automatic nervous system. It's been an autonomic,
Yeah.
just to bring it down, make you understand it. For example, we sleep, our heart beats, we breathe during our sleep. All of that's controlled by the autonomic nervous system or the automatic nervous system. And this syndrome affects this in particular.
Correct. Typically, it affects the things we don't think about or have no volitional control over.
Mm-hmm.
Okay, so things like you said, breathing, heart rate, regulatory function in terms of blood pressure, thermal control, how our temperatures regulate. These are all auto-regulated. We don't really have much to do with that.
Correct.
The two systems that are present in that realm of automatic is the sympathetic system, which is the flight or fright side. You see a train coming at you, your heart rate and blood pressure go up. Mm-hmm. And then there's the counterbalance to that, which is the parasympathetic side, which is governed largely by a cranial nerve called the vagus nerve. Mm-hmm. The vagus nerve innervates typically virtually every organ that we have and has influence over those. And it is these two systems that become deranged in their autoregulatory capability during not only the syndrome of POTS, but for a whole slew of other illnesses. For instance, you have to really rule out organic or structural problems with the body before you can actually include this as a solitary entity. POTS is something that you would label someone as having if they do not have concurrent illnesses such as diabetes, which causes diabetic autonomic neuropathy. All right? The neurons are destroyed, and you'll lose autoregulatory capability in that respect. You also can have things like Parkinson's disease, which is a neuronal problem, but the central nervous system, imbalance between acetylcholine and dopamine, which disorders that, and they lose balance and so forth, but they can also develop secondary autonomic peripheral problems associated with that, loss of balance, tremulousness, and that kind of thing.
Got it.
So, there's a lot of illnesses out there that really need to be identified first, or at least included as possibilities that would essentially exclude this diagnosis. So,
correct. And you mentioned they see 5 or 6 physicians before they get to the real person, the cardiologist. That shows that this particular syndrome is quite complex.
It is.
And sometimes confusing and sometimes missed.
Yeah.
So, therefore, it's nice to know that the buck stops at the cardiologist's office and they find out what's wrong if you don't figure it out yourself.
And you know what? Any cardiologist you talk to will tell you that this is not a cardiologic illness. The heart is actually responding to what it's being told to do, or inappropriately what it's being told to do. So,
inappropriately.
Yeah. Mm-hmm. So the fact is that we stand up all the time. Posturally, we change our body position, and the transmitters and the systems that allow us to detect that and send messages to and from the central nervous system are not doing what they're supposed to do.
Got it.
And so this is why the people come in with dizziness, fatigue. I'll tell you, fatigue happens to be the most common complaint with these folks. Mm-hmm. They have GI problems, usually autoregulatory problems with the GI tract. For instance, irritable bowel syndrome or intermittent constipation with diarrhea. They have migraine headaches. The vessels in their brain expand and contract without provocation. Mm-hmm. They have Raynaud's phenomenon, which is a constriction of the fingertips. I call them patriotic fingers. You get triphasic coloration of the fingers,
red, white, and blue. Yeah.
And they get other manifestations of this. And however, what you really need to do is make sure that they just don't simply have Raynaud's phenomenon and not this other entity we call POTS.
Right.
So there have been attempts by many out there. It depends on who you talk to. Neurologists want to pigeonhole this into a neuronal disorder. You get cardiologists that sometimes think it might be related to volume status. Mm-hmm. And there's the central nervous system derangements, which are primarily not peripheral but centrally located. And they try to pigeonhole them into 3 main categories as the neurologic POTS, neuropathic, the hypovolemic POTS, and the central adrenergic. Of the 3 general classifications, and I might add, any one person can have components of all 3 of these. Mm-hmm. But the one that predominates, or at least it's more prevalent, is the hyperadrenergic variety. about 40 to 60% of the folks that present have that form, and that manifests itself much like you see on the Snickers commercials, where people get hangry, they get agitated, they get tremulous, their heart rate goes up, they start sweating, they do all this stuff. It is the hyperadrenergic side or the sympathetic side that predominates, but it's an inappropriate state of that.
Right.
And
dysautonomia. Mm-hmm.
Yeah, it's an inappropriate. Whenever you have a dysautonomia that creates all these symptoms, and it's not supposed to be in that circumstance, then you have that precondition. I want you to know that statistically speaking, this is not a rare illness. This happens in about 1 in 500 Americans. About 3 million Americans are therefore estimated to have the condition. It is predominantly a 5-to-1 ratio with female to male predominating. So a lot of women come into the office with this. I can't recall the last time I saw a guy with POTS. So most of the time I see women with the condition. And it has certain characteristics to it. For instance, the folks that come in are typically those that have had some form of trauma that predated it, maybe 3 to 4 months earlier. They've had either physical or emotional trauma. Sometimes they have situations in which they've had a recent viral illness. And, we would just get over the pandemic, or I don't know if it's ever going to get over, but we've gotten out of the circumstance where we're not traveling with masks everywhere. And,
right.
And we have had an uptick in these kinds of symptoms in folks that either got the vaccine and were concerned that the vaccine may have caused some of the problems due to an immunologic response, or it may actually have been the virus that created the problem and enhanced the immune system. There does seem to be evidence, although there's never been trial data. By the way, there's never been any trial data to come up with a specific etiology for this. There's some data out there that suggests that immunologic causes for these symptoms and syndrome are not to be trivialized. There's a lot of different syndromes out there. Connective tissue diseases, lupus. You got post-viral syndromes. You've got Guillain-Barré. You've got there's a
many
lot of
autoimmune disorders.
Yeah, many autoimmune disorders that kind of step up the system and respond to the make the host very responsive to a trigger. Although no definable trigger, no specific trigger has ever been defined.
Well, then, in review, then, there are certain types of POTS. You have the neuropathic type,
right,
where the small fibers that regulate vasoconstriction are affected. You have the hyperadrenergic site, which is the fight or flight, in which you have elevated levels of adrenal-like hormone.
Yeah.
And then you have the hypovolemic type, which you lack volume.
Yeah.
And there are secondary types, which you've mentioned, coming about secondary to things like autoimmune phenomenon, even Lyme disease, diabetes, and this can all produce these similar type effects.
This underscores the importance of taking the time with the history and physical. The tendency by a lot of subspecialties and a lot of the residents and fellows coming out of their training is to test in order to make a diagnosis. This syndrome, if properly questioned, an individual is properly questioned and a good history and physical is done, this syndrome can be identified, at least in terms of its presence, its recognition. And a lot of the other things that may mimic those symptoms can be excluded.
Correct.
Okay, so, it typically hits women to men between the ages of 15 and 50. So right off the bat, if you've got someone sitting in your office who's complaining of having tachycardia and they're 78 years old, like I see most of the time, Medicare patients are 78% of my practice.
Probably not related.
Probably not POTS. Okay? I'm not suggesting that person could have had POTS for 30 years and just didn't get diagnosed. I'm just suggesting as a new onset bunch of symptoms, it's not likely POTS. On the other hand, if you got a 15-year-old, somewhat neurotic young girl sitting in your office, there's a greater possibility that it exists, and it's not necessarily related to their anxiety. They've often been mislabeled as being someone who's psychosomatic or anxious, or
but you said she was a neurotic to begin with.
Well,
so
someone who appears to be that way.
Okay, gotcha.
Yes.
Gotcha.
And that's the thing. They get labeled sometimes before they come into your office. You'll get a phone call from a referral. I'll get a referral call. I got a woman who's neurotic, blah, 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 and automatically you have that in the back of your head, so this must be someone who's got an anxiety problem. Yeah, many of them do have that, but that's not the defining entity for the syndrome we call POTS.
Maybe the syndrome's causing the anxiety.
And you're right. And it's a self-propagating problem.
Got it. That's why it's so difficult to diagnose this, because of the many organ systems that's involved with it, right on down to the psychological system, which, sometimes you have to just go with your gut on that. Now, that's why it's called the invisible illness. The invisible illness. Why invisible? Because I guess you don't see it.
I saw an interesting article about, it was a cardiologist presenting the talk at Hopkins, and he had 6 cardiologists who were blindfolded, and each were put at a different part on an elephant. And they were asked to perceive what they were feeling, and they all had different opinions because each of them had blindfolds on, and it was a cardiologist, an allergist, a radiologist, and they were all looking at their own specialty. And so it must be this, it must be that, it must be this. But if you have blindfolds on and you're only getting a piece of the picture, you're never really going to get the whole thing.
Got it.
And then he thought the joke was that in order to fix that, you get a whole lot more cardiologists to look at it. And eventually what you have is 500 people looking at it. And eventually, maybe if you've got a cohort of people looking at this elephant, you'll come to the conclusion that it's an elephant.
Wow.
It's an interesting thought process, but it's probably true. What happens is you got a bunch of, in common practice today, I'll see the patient and never communicate my thoughts to the allergist. Mm-hmm. Or the allergist has this input and it never communicates that to the neurologist. It takes a cohort of docs who can put all that information together and say, this is likely a form of POTS, and we can go at it by doing X, Y, Z. What you have is a primary care doc who gets all this information as independent of viewers, and then the patient doesn't know what's going on. You're trying to put it together because now you got 3 consultants with varying opinions as to what's going on. The bottom line, the patient doesn't get treated, or doesn't get completely treated, or can treat it in an inappropriate way. And I want you to know there's no medicine out there on the market right now that's been approved for the treatment of this entity. Not a single one has been approved by the FDA. Anytime you give a medicine, and we'll get into that in a minute, anytime you give a therapeutic option in terms of a medicine, you're using an off-label indication.
Of course, yeah.
And docs are really reticent to do that these days. When it's hard enough giving a medicine when it is indicated and running the risk of having a problem, as opposed to having an off-label drug for the presumed benefit, specifically if it hasn't been fully labeled. I mean, some people can come in with some degree of hypovolemia and dysautonomic syndromes, and I would venture to say that virtually all of them have some degree of hypovolemic state. There is a precondition of hypovolemia, for instance.
Lack of fluid in the bloodstream.
In this intravascular compartment. And that's a precondition for having a basal state of heightened adrenergic tone. So their epinephrine levels are higher, heart rates are higher because they simply are intravascular. Within the blood vessels, they're low in volume.
Right.
That's a baseline chronic state that may exist.
Right.
Then you superimpose on top of all that the hyperadrenergic or the central adrenergic components, in which there's deregulation of sympathetic versus parasympathetic tone, and now you've got a combined reason for having heart rates that are constantly up and changing dramatically with body position. So if you treat one aspect of it but you ignore the other, you're not going to take care of all the symptoms. And I might add, if you treat one and it has an adverse effect on the other component, you can actually make things worse.
Right.
So you've got to be real careful about throwing medicines at these folks, A, because now they feel like they're ill. They have a real illness that they need to combat, but it's poorly defined. And 2, it may actually create some of the very problems you're trying to take care of. Part of the problem has been just that. For instance, if they're mislabeled as being someone who's just neurotic or anxious, they're getting SSRIs, serotonin reuptake inhibitors, and they can create the very problem that we're trying to take care of.
Interesting.
The serotonin reuptake inhibitors are actually contraindicated in several of these things because they'll actually make the adrenergic variety, central adrenergic, worse.
Okay.
So we have, and they'll also make the plasma volume decrease. So So you have to be careful about just throwing medicines at them for a presumed solitary psychiatric problem when it really is not that.
Got it.
It's a physiologic problem which has multiple implications on how the nervous system doesn't really handle things well in terms of position.
The differential's so great on
It's
this.
huge.
I mean, it's huge. So you got to go down the line. And like interestingly enough, I had a POTS syndrome patient in my office today, and we went through a differential. And I said, let me list the differential diagnosis to what you have. And it was about 10 things at least. And so I said, what we do to find out what's wrong with you is we test, we eliminate one at a time till we get to the answer. And she fully understood. And it's quite an interesting set of syndromes. And I don't know, in my training back when, this wasn't discussed, and as you mentioned, even in your cardiology studies back then, it was never brought up and never discussed at all, because I'm not sure it was really considered. I'm not sure it was really known. So
it wasn't. It was first coined in 1993 at Mayo Clinic by a Dr. Lowe. So we've known about
when
1993.
Okay,
that was when Dr. Lowe at Mayo Clinic first coined it, and the definition hasn't changed much in the last 30-some years. But in that 30-some years, there's never been a double-blinded crossover trial that indicates any therapeutic modality is beneficial. There's never been anything to identify groups of patients who have specific and similar symptoms, and then tested that population.
Wow, interesting.
Not a single trial.
Wow.
There's meta-analysis looking back at studies, looking back at data pools, and saying maybe there is some correlation here. But neither in the United States or even in Europe, England, there has never been a set of trial data that has any sufficient power. Small trials, 20, 30 patients of no power at all, and generally speaking, useless in terms of being applicable to my practice. There's never been any big trials that would indicate that any specific medicinal therapy is the specific therapy for that.
Got it.
That's why the FDA has not approved anything.
Wow.
However, I don't want people thinking, based upon our conversation, that there isn't things we can do that would make their quality of life better and make them go forward in a more desirable way. First off, I think our listeners should know that there's not a single recorded death from POTS. That's number one. That number two, it can alter your quality of life, how well you live, but it doesn't shorten your life. There's been no evidence that POTS, when you look at that group of people that have been accurately labeled, have a shorter lifespan on that basis alone.
Right.
And that's really important because other things that can mimic the symptoms do have an adverse effect on your lifespan.
True.
True cardiovascular disease, one of the first things I do in part of the history in physical is physical. And one of the first things I have to do as a cardiologist is eliminate structural heart disease, because that's really
what you do.
A whole different ball game. If your heart rate's up because your heart's not squeezing well, okay, that's a whole different ball game, and that can't possibly be POTS. That's a whole separate thing. And I think for many of the people I see, that's the real reason why they're being sent to me, is to make sure that they haven't got a cardiologic reason for having the tachycardia.
Understand.
And it has to be defined as normal sinus tachycardia, because we have all kinds of tachycardias that are not normal.
Correct.
that can make you feel like crap. Pardon the vernacular, and you can miss those. They can be misinterpreted as being sinus tachycardia.
Okay, before we go on with treatment, diagnosis, what do you do to diagnosis, and some of the symptoms that are common with this particular syndrome, I'd like to take a break right now, and we will be back with Dr. Lewis.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
Hi, it's Dr. Nick Biasotto, back from our break on our podcast from the Medical Society, Delaware Health Care Reality. And today we're speaking with Dr. Ron Lewis, who is discussing POTS syndrome, which is quite an interesting syndrome. It's quite complicated. I imagine the differential diagnosis, meaning how many possibilities you have when you see a patient with this, is very long, and you'll gradually eliminate one thing at a time till you get down to the fact that it is POT syndrome. Ron, tell me a little bit about the most common symptoms you would see with this syndrome.
Almost always, I think the most common symptom is fatigue. There are constantly, their life is marked by fatigue, and this is an important common thread. Another common thread is the fact that when they do stand up, they're dizzy, but they don't pass out, and that's an important clue that this might exist. Another is they get unexplained muscle aches and pains, and it's not necessarily while they're actually using that muscle group. It's afterward or delayed muscle pain, and it's often been labeled, and again, I'm not sure, fibromyalgia, and whatever that might be, and whatever might cause that. There's disease processes that fit the decades in the past, and that was one of them. Another one for me was mitral valve prolapse. I would venture to say that 90% of the people that were labeled in the 80s as having prolapse really don't have it by strict criteria that we have today. But diagnosis of convenience, one of them was fibromyalgia. And in fact, it could have been one of the complex symptoms of having this entity that was, again, not recognized.
Right.
Okay. So the ones I see as a cardiologist are those, although by no means are they the only ones. Folks will have GI symptoms and therefore have already been seen by a gastroenterologist. One of the other things that's common is brain fog. They have cognitive impairment during the day. They feel like they're constantly in a fog, and one of the things that leads me into another realm is, could this be related to the fact that they have sleep disorder? And another common thread is that all these people have sleep disorder, and a lot of them have morning or daytime headaches, which may or may not be vascular. Okay. One of the things I screen all these people for are the things like sleep apnea. If they're having disordered sleep at night, they're at risk of having these autonomic and deregulatory problems during the day. So I find that headaches are common. They have a constant state of, I call it a constant state of disability. They just don't feel like they can do anything without getting into trouble. They have a hard time exercising because they have decreased endurance, increased fatigability. They have all the other things that we mentioned, and that's why they get sent to me. The other thing that's interesting is that that these symptoms, as you know, are not unique to any one entity. There can be 100 different illnesses that can present this way.
That's why the differential's so long.
And why you have to really do a good exam and a good historical background. There are certain historical features to these folks that can differentiate very quickly them from other ailments that might cause them to have the same symptoms. And a lot of these things do not require a whole slew of diagnostic tests. We do this thing called a tilt table study.
Yeah, we'll get to that.
And we also do this in the office. You can do what's called orthostatic testing. You lay them down, and you keep them in a steady state for 10 minutes. You say, I'll be right back. Let them chill, because they see me, they get upset, and then you come back and you talk. And I said, I'm going to lay you down, and then we have them stand up abruptly. The heart rate, if they have the circumstance of having POTS, will jump dramatically from, like, say, the high 80s to 120, 130 within the first minute. And then you keep them there. And you don't stop there. You check their blood pressure. And the key about POTS is the blood pressure doesn't drop initially. If it does, it's not POTS. You can't label it as solely POTS. It could be orthostatic hypotension, and it may be a hypovolemic state, which goes beyond just simply the hypovolemic kind of POTS.
Meaning they lack the volume in their bloodstream,
and there may be
which
reasons
is causing
for that.
the tachycardia.
They may be on diuretics. They may be anemic. They may be people who are anorexic. I'm not talking about anorexic because they have other ailments. They may have anorexia nervosa or some other. These are folks that need to have that identified and treated as a way of preventing the tachycardia that changes with posture. On the other hand, POTS folks, they get up, their heart rate goes inappropriately high, and their pressure stays normal. The rhythm, by the way, is sinus tachycardia. It's a normal tachycardia. As cardiologists, we never really treat sinus tachycardia. We treat the cause for it.
Right.
So if your temperature is 104 and your heart rate's 120,
It's
you don't treat the
perfectly
you don't treat the
normal,
tachycardia. You treat the temperature,
Right.
so the fever. So the idea is understanding. You always go for the cause. And unfortunately, for POTS, what's frustrating for cardiologists at least is that there's no thumb. You can't put your thumb on any one thing that causes it.
Got it.
You got an infected bladder. You got pneumonia. You've got you've got an illness. You can put your hand on that and say, okay, your heart rate's up because you got this illness, and it's time to treat that, and then eventually the tachycardia will take care of it. So.
Got it. You mentioned earlier that usually seen between teenage years and 50 as an
Yes.
average
Yes.
time when this period does occur, and more in women than men. Is there a genetic basis for this in your mind?
Not one that's been clearly defined.
Okay.
No. There have been genetic predispositions for fainting, for syncope, for actually fainting. For instance, vasovagal, orthostatic fainting, cardiogenic fainting, but not necessarily for POTS.
Got it.
Okay? So, and remember, again, a hallmark of POTS is that it doesn't cause people to faint. It makes
They
them
get
feel lousy,
dizzy.
but they get dizzy. And I'm not suggesting that POTS can't have concurrent vasovagal or reflexive forms of passing out.
Got it.
Which makes this really more difficult because now you're chasing your tail a little bit, because to prevent this thing over here, you may actually worsen this thing over here.
Wow. No wonder this thing
Okay.
has been so confusing over the years.
Yeah. Now, vasovagal, as you know, is that whole reflexive form of passing out is created, again, by the vagus nerve that innervates the parasympathetic system, which brings you down. Okay? And in that component, there are two types of responses. One is a drop in blood pressure, which is what vagal stimulation does, is it causes blood vessels to go from 2 inches to 4 inches, drops the pressure when you got the volume that's fixed. And the other thing it does is a cardioinhibitory effect, which it means it slows the heart rate independent of the vasomotor. So you get two reflexive changes, and they're not balanced. One can be predominant, so you can get a drop in heart rate where they can actually stop their heart rate for 7 or 8 seconds and pass out on that basis, or they tank their blood pressure and the pressure is not supportive of cerebral perfusion, and they pass out. Generally speaking, the vast majority of folks are a combination of the two. That clearly is differentiated from POTS because pressure doesn't change with POTS, and they don't get the prodrome. They have that prodrome of pale, sweaty. What they get with POTS is sustained. With neurocardiogenic, they get it, and then within 3 minutes, they're out.
Wow. Okay. All right. Now, very interesting, that adds to the confusion of this syndrome, is the coexisting conditions that can occur with this, such as chronic fatigue, migraines, fibromyalgia. We talked about those. How about Ehlers-Danlos syndrome? There's some commonality between that and POTS.
And you're right. And with Ehlers-Danlos type 3, which is the kind we're talking about here, first off, there's 11 different kinds. The one that's the hypermobility version, which is the type 3, you see these people on AGT, and these people can contort themselves into all kinds of shit. They probably have a form of Ehlers-Danlos.
Okay.
And they have, as a result of that connective tissue dysfunction, if you will, sympathetic nerve fiber deregulation peripherally, not centrally. And as a result, they have all kinds of autonomic, they can develop autonomic derangements on that basis. The Ehlers-Danlos type 3 is pretty easily diagnosed. They typically have hyperelastic skin. They can actually put their arm on a table.
They're like double jointed, as we
double
used to
joint,
point it.
and they can take their arm off and have an inverted U with their elbow.
You can
they're
take their
hypermobile.
thumb and bring it
They
all
bring it
back
up
to
and
their
touch their forearm, and
Yeah,
they
I've
can
seen
do all
that.
kinds of things that you and I would have. I mean, hyperelasticity, where they can actually turn themselves inside out and that kind of thing. So those folks are at risk for developing POTS as well on an autonomic basis or an autonomic derangement. We have to make sure that you know that the patient is diabetic, because they also have, it's a very common
problem.
It's another problem. Anybody that has a neuromuscular disorder, dystrophies, myotonic dystrophy, Duchenne's muscular dystrophy, those things can have effects on both sympathetic and non-sympathetic.
Right,
The
exactly.
dystrophies are muscle, but generally speaking, acetylcholine imbalances can cause similar kinds of problems.
Got it. Autoimmune disorders, as we've already mentioned, lupus and the like, can be part of coexisting conditions with POTS. Tell me a little bit about mast cell activation syndrome.
Deactivation, yeah, that's where you have these are cells that are in our body everywhere. You know, you've had a situation where if you take you have a predisposition to, like, say, seasonal allergies. You're what they call an atopic allergen, and you draw a letter on your forearm. Kids do this all the time. You'll see the letter that you've made, and what makes that happen are these mast cells that sit in our epidermis, and they have these granules in them that contain substances called histamine and sometimes serotonin. And histamine is the thing that makes the blood vessel in that area dilate. So basically what it does is the capillary we're talking about becomes twice its normal size, and it allows then the intravascular component, the water component of blood, to get into the tissue, and it makes it indurated and hard. You know, and that's how you get to see that. And it also turns it red because of another substance activation, which is called prostaglandin, and those things cause vascular bed expansion. And when that happens, you can get a drop in preload or return to the heart if it happens to be a systemic effect, and it acts like the hypovolemic version. There has been loose association between those two things, but no trial data to suggest that that's actually a thing. It is immunologic, which indicates that there's probably a true immunologic contribution to POTS, but I have not come across any data or any supportive study that would indicate that that's an actual association.
I gotcha. Well, hives is a big effect of a mast cell activation syndrome. Now, many of our listeners, and maybe even many of the physicians out there, do not really bring to mind the median arcuate ligament syndrome, in which the celiac artery is affected, leading to many GI symptoms that are been knocked around with irritable bowel. Make sure you don't have a tumor there. Don't do this. When it's actually a compromised celiac artery, that may have some association also with this POTS.
And actually, not only that, but there are other syndromes that actually can cause the same thing, where you get pelvic congestion on the basis of the iliac artery being compressed. Same idea. You oftentimes have inferior vena cava syndrome in pregnant women who can present with inappropriate tachycardias, and that has another organic or real reason for having tachycardia.
This should have been named confusing syndrome.
Well, yeah. I think we should pan the pots. But the bottom line here is that you have to really pay attention to other things that can cause tachycardia before you want to just throw a label on this.
Got it. All right. Now, we've talked a lot about this. It's very interesting. Can you definitely tell me how to diagnose it, and give me one test that would be almost pathognomonic, meaning almost labeling it as POTS syndrome? Is there such a thing?
No.
Okay.
No is a complete sentence in this regard.
Okay.
There is no pathognomonic test. There's no diagnostic lab value. Whereas in cardiology, we have a lot of things that we can use to mark as markers for structural heart disease. There's not a single diagnostic test that is pathognomonic, which means it's specific toward the diagnosis of POTS, and that is part of the problem, because we're breeding test takers. We're not breeding clinicians anymore. We have a lot of students and residents and fellows coming out of school.
Ain't that the truth?
Who've lost the art of asking the right set of questions.
And using their hands.
And using their hands and their eyes and what the good Lord gave them as a way of making a diagnosis. Right. And that's really key to this. First of all, it indicates to the patient when you do this that you're interested. In other words, you're just not another crazy person who needs a couple more tests to take. That's number one. Number two, you're spending time with the patient. And one of the things that's most valuable to us as doctors is our time. But if you're going to make this diagnosis, you're not going to do it in a 10-minute visit. It's just not going to happen. These patients take up probably most of the time I have in the office in terms of making a diagnosis. But it's important because, A, they get the sense that you're empathetic. 2, you're compassionate. 3, you are recognizing that what's bothering them, this is a big issue for them, is not their head, but
it's
their
real.
body. It's a reality. It's a real thing.
Yep.
And when they get that sense, that in itself goes a long way in terms of allaying a lot of the symptoms that they have.
Mm-hmm.
And I find that when you tell them, look, I don't think it's X or Y, I think it's a combination of these things. When you look at it as a combination of things, you're going to be more accurate than trying to pigeonhole it into one defined entity.
Mm-hmm.
Okay? And that then leads us to how we go about maybe overcoming some of the symptoms.
I have a lot of students that come through and do their rotations with me in primary care, and the first thing I tell them when they walk in my office is, I want you to get a good book on physical diagnosis, and I want you to read it from cover to cover. Why? I said, because you want to beat that test before you get the results of that MRI and that CAT scan and that EKG. I want you to tell me what's wrong with the patient before we get all these. That makes you a doctor.
Well, the point is, I try to convince cardiology fellows sometimes that the echocardiogram doesn't make the diagnosis.
It
confirms
right.
it.
That's exactly right. Let the test confirm
what
your
you
diagnosis.
already have as a clinical suspicion.
Okay, so what's that test? You mentioned earlier the tilt test.
Yeah.
Okay. Kind of describe that briefly.
Yeah, I'll do it briefly, but I want to preface what I tell you by saying that I almost never order one for this diagnosis. I'll do it in order if I'm being pressed into doing it by the patient. He heard about it and they want to do it and get it done.
Mm-hmm.
I'm okay with that. But for many people who actually have POTS, this becomes a point of tension, a point of anxiety. And the question then it becomes, is the test predictive of the ailment, or is the apprehension and the pre-test concerns that they have a bigger point?
Got it.
You follow?
Mm-hmm.
So for many, and again, this is all about judgment. The person sitting in front of you can come in a bundle of nerves, a bundle of adrenergic stuff. The hypovolemic people have a greater application, I think, in this regard, because it will differentiate
the tilt test
a little bit.
Mm-hmm.
But the tilt table study is real simple. It's a simple study. It's for the clinician who's monitoring. It's boring as heck.
Mm-hmm.
I saw a cartoon in the American College of Cardiology where the caption was a positive tilt table study, and the patient sitting on the table vertical with their eyes wide open, scared out of their mind, and the doc and the nurse are passed out.
That's a good one.
Okay. All right. So this is a really, from a medical standpoint, it's a very boring test for the people monitoring. But for the patient, they get put on a table. It's a basic radiologic table. They have a pill on their head, footboard. They get an IV in, IV's running. They get put on an EKG machine, and a blood pressure is automatically taken every minute. And they're strapped in. Mm-hmm. And then they raise the table to 70 degrees.
Doesn't hurt. It's pretty simple.
No pain. Most important. Many people will pass out by getting the IV. The vasovagal people, you'll die fine right away. Okay, you don't have POTS, you got this. But we put the IV in, run the saline as a cavia, just keep the vein open, and we watch. If they have POTS, you raise the table, their heart rate jumps from 80 to 90, right up to 120, 130, and it stays there. Pressure cuff shows pressure is not variable.
Okay.
And you keep them on. It rarely does it take more than 10 minutes to make this diagnosis.
With that.
Mm-hmm. However, you could do the same thing, if you will, in your office.
True.
And they're walking into your office. Remember, these people aren't coming in on gurneys. They're coming into your office upright. Mm-hmm. So they're walking in. You take their pulse. It's 128, 130.
Already to start.
And so you have to put them down.
Right.
So you have to. All right. Well, I'll be back.
Lay down.
I'll be back in 10 minutes. Get your steady state, and then I'll do it in the office.
Well, it's a simple tilt test, isn't it?
It is.
Okay.
It saves the patient all the aggravation. So I can make the diagnosis but that still doesn't define it as only POTS.
Okay.
So what you do is you keep them on the table, and you watch to see what happens later on, because they can actually be a POTS circumstance, but then they can develop venous pooling in the legs, and they can actually lower the pressure over time. Mm-hmm. So there may be a combined entity. Or you may actually trigger a vasovagal response.
I like that. Now, I got that patient who comes in, and I'm going, Could be, maybe, not me. What tests would I order to make that differential diagnosis smaller to get to the answer?
A basic metabolic profile, comprehensive metabolic profile. You just do all your electrolytes because we really don't want to have a problem. It's hyponatremic. Sodium levels are low. Serum magnesium, as it turns out, is very important. Because vasomotor tone is regulated by that. You want to make certain that thyroid functions are okay. You want to make sure, obviously, they're not, frankly, diabetic. Sugar's not 300, which in turn will cause plasma volume to decrease. You want to make certain that
CBC, they're not anemic.
Right, you want to make sure they're not anemic. Although a lot of these features are historical features or they're clinical features. A patient comes in looking like a ghost, they're anemic. So it doesn't. The point is, you're going to be able to eliminate a lot of things by simple labs. And it's not to define whether they have POTS or not. It's just to make sure that they haven't got something else going on that may mimic POTS.
How important are cortisol levels? Are they?
Very rarely are they helpful. Very rarely are they helpful. And remember, cortisol issue in terms of it being low is going to be almost always associated with a drop in blood pressure when you stand up. So if you had orthostatic changes that were positive for drop in pressure, then I would get a cortisol level and you'd be out of POTS already.
Got it.
Okay.
All right. Now, we talked a lot about this. It is confusing and multifaceted. It's quite an interesting syndrome. We make the diagnosis, yes, this is what you have. You have POTS syndrome. What's the treatment? Okay. Since the symptoms are driven by one or more of the types that we talk about, volume issues, adrenergic state, neurogenic, the goals of therapy are actually lifestyle change. Very important. A lot of these folks typically don't drink enough, they don't eat enough salt, they don't get enough sleep, they overdrink in terms of alcohol, and they don't exercise. Okay, a lot of the folks are volume contracted simply because they don't do what we do. They don't hydrate. And you say, well, how much do they have to hydrate? Well, for the folks that actually do have POTS, the amount of volume that they got to drink on a day-to-day basis in excess of what they normally would drink at meals is about 4 to 5 liters per day. Wow. And they have to eat an equivalent amount of salt. The magic numbers are 4 to 5 in liter, 4 to 5 in grams of sodium. Almost always they either have a relatively low sodium or they're sodium deficient. So for some reason they don't have enough salt. And as you know, if you don't eat salt in addition to drinking water, your kidneys are just simply going to get rid of it. Right. When you put these people in a lab and you put a liter of saline into the hypovolemic versions of these folks, and they're all relatively hypovolemic, they do remarkably well. They feel 100% better by getting the IV. Now, I'm not certain whether this is an immediate plasma expansion in this normal saline, or it is a placebo effect, or both. But the fact is they get precipitously better by giving them IV saline. Yeah. So if you can give them or get them to drink lots of salt water, essentially. 4 liters a day, 5 to 9 grams of salt a day. And this underscores the importance of making sure that what you're doing is appropriate, because if they have structural heart disease and their heart rate's up because their ejection fraction is 10%, you're going to put them in the hospital. Right. Okay, so you got to be real careful in making sure that you're certain that structurally speaking, this person's in good shape. Got it. All right. That's one of the things. Where's exercise? How's that playing? Exercise is really important because the problem with being in a deconditioned state is the sympathetic system is not accurately responding to the physical need. And as a result, you're not getting the compressive needs in the calf muscles and the legs to get the blood back up to the brain or up to the heart. And it's important to know that when sympathetic nervous system doesn't respond in an appropriate manner to the desire, the need, you get lactic acidosis. And as a result, you get vasodilation. Right. And it contributes to the very thing. The problem you're faced with these people is that they complain of being fatigued. And they're having a hard time with muscle aches and pain. So they have two problems right from the baseline that would negate their willingness to want to exercise. But there's ways of overcoming that. First off, it's recommended that they do supine exercises that are semi-recumbent or recumbent. Right. Aquatherapy. Things like that, where they're not required to be upright, are valuable because it gets the muscles working, resets the sympathetic nervous system in response, and they get somewhat of a training effect. But they're more or less in a supine position.
And they're less likely to become symptomatic.
Got it.
When you look at their quality of life indexes in that kind of exercise, there is a positive response
Right.
in terms of how they feel,
Mm-hmm.
even though they're fatigued all the time and they have
I
muscle
know,
aches
it's
and
like-
pains.
yeah.
The very thing. So
Paradoxical.
there is, I must uniformly tell them not to use any illicit or substances, and I also tell them to knock off alcohol, because alcohol dehydrates you.
Now, compression hose. They all mentioned in my readings compression hose to stop the pooling of fluid in the legs.
Yeah, there's 2 points to that. One is that they need to be, if it's going to be used, they need to be fitted, because not one size fits all, right?
Correct.
So they need to be fitted. They usually have to be medium compression. Anybody gets high compression is never going to wear them because it causes pain.
Mm-hmm.
And remember, these people have pain to begin with. You don't need a stocking to make it worse. If you got a person who's got some form of debilitation and fatigue or weakness, getting those things on and off is a pain. And the other thing is those stockings typically have to come above the knee.
Mm-hmm.
If you have them below the knee, what you'll get is the ring around the shin syndrome, and that's not going to help anything.
Gotcha. Okay, pharmacological treatments. Medications, you said earlier, I usually don't use medications, but
Very rarely.
I've read that, fluorohydrocortisone, midodrine, beta blockers. Talk about those.
Yeah, and this goes to the knowledge as to what you're dealing with. If you're dealing with a relative low volume and you have the sense that that's part of it, things that are volume expanders like Florinef, it will work to help in that regard. If it's adrenergic, for instance, then you have an opportunity to use a beta blocker, but again, you got to be real careful about using beta blocker therapy in someone who has, for instance, a history of depression or depression anxiety loop, or they have other forms of ailment that are coinciding with this that may aggravate those symptoms and then create the very problem that you're trying to prevent.
Got it.
There is a medicine out there, ivabradine, which is Corlaner, which is a medicine that's been approved by the FDA for the management of heart failure with reduced ejection fraction. Mm-hmm. It's an interesting drug, and the way it works is by inhibiting the I receptor. It's called the funny receptor in the sinus node, and what that does is it slows heart rate down. So for the adrenergic person,
that'd be great.
The problem is that it's not indicated for the use in pots, number
Right.
one, and number two, it's extremely expensive.
Okay.
So there
Then
are
that
obstacles.
rules that out.
Yeah, for most of my patients, it rules it out.
Now, midodrine.
Yeah.
Now, you would think midodrine, which is a stimulant, would cause the heart rate to go up.
It's a vasoconstrictor, actually.
Yes.
And it can cause paradoxic rises in heart rate, but if you get preload back to the ticker, the heart rate won't appreciably rise. You follow that?
Keep compression hose on and take midodrine.
If you take midodrine, you cause a 5-inch pipe to become a 2-inch pipe. You're actually increasing preload back to the heart. So the offset for the adrenergic stimulation is the fact that you're increasing preload, and the heart rate doesn't go up so much.
Okay, gotcha.
Problem with midodrine is if you got structural problems with circulation, like coronary disease or any other
You don't want to mess with that.
You don't want to mess with that.
Got it. Anything else, Ronald?
Well, the other thing we didn't mention is if these people coming in, like sometimes we get young women coming in because they get a little swelling in their feet at times, and they have PRN doses of diuretics. I nix all the diuretics, just get rid of them. Avoid sleeplessness. It's really important to get the sleep issue squared away. Vasodilator therapy. You got to be careful. A lot of guys that are young or not so young want to use vasodilators for other reason, and that can precipitate huge changes in heart rate.
By that you mean
Cialis,
Viagra,
yeah,
right?
Especially if they're on vasodilator therapy for things like high blood pressure. So you can combine issue. Caffeine and nicotine, very important.
Good stuff. No.
Love it. No, but no, caffeine and nicotine you got to really, because they're stimulants as well. Folks, I often see times folks who are young who are on ADHD and ADD medicines, and they can actually create circumstances in which the heart rate response to standing up can go up as well.
Very good. Wow, this has been a very interesting conversation. I've enjoyed it. I've learned a lot, and I'm sure our public has learned a lot. So anybody out there that thinks they have POTS syndrome, See your primary care doctor, mention it, and see if he can figure it out before it gets to the cardiologist, which is the last man standing.
We cardiologists would greatly appreciate it.
And the cardiologist would greatly appreciate it, because I could see where POTS syndrome could be quite frustrating. Well, we've been speaking to Dr. Ronald Lewis, who has given us an excellent presentation of POTS syndrome and what it's all about and how confusing it sometimes can be. This is Dr. Nick Biasotto, the host of your podcast from the Medical Society of Delaware, Delaware Health Care Reality. And thanks again to Dr. Ron Lewis, and
It was my pleasure.
See you next time.
This has been Delaware Health Care Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Mitten. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the hosts or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.